So here's the model that Glidewell has provided us, and what we're going to do is we're going to place an implant in the mandibular, first molar, and first bicuspid area. We will, they've provided us, at least me, a 4.3 diameter by 11.5 diameter Hahn implant, tapered implant, and a 3.5 by 11.5 millimeter Hahn tapered implant. And to open them, we simply open the box, and the implant comes sterile packaged with a cover screw in position. There's also two labels here, and these labels are very important. I've recorded every implant I've ever placed, so I would suggest we get a little notebook and put the date, the patient's name, and the type of implant that you place with a little sticker. I like having a little notebook to do that. For the patient's chart, you can scan the second label and place it in your patient records. To open in the packaging, you simply grab on, open, and simply dump it on the tabletop. And we'll put these aside for now and demonstrate their use in a few minutes. And here's the 4.3. Now you're going to notice something here as I emptied this. The 4.3 is yellow and the 3.5 is magenta. But the cover screws are both magenta, and what that indicates is that the internal design of both those implants is identical. So all the components, the internal components for each of those implants are identical. Let's put these aside for right now, and let's look at our model. So when we're determining implant placement, as we've demonstrated clinically, we want to determine correct position, ideal mesial distal buccal lingual position. And so I'll simply take a Sharpie or a pen, and I will do this intraorally in the mouth. And let's do the molar first. Is I will draw a vertical line on the bicuspid and one on the mesial cusp of the molar. And basically we've created field goal posts. And where does a football player want to kick the football? Directly down the center. And so I'm just kind of eyeballing it of where I think basically the center is. Now, buccolingually, we want to follow the central groove, and I will oftentimes just draw a line on the tissue of where the central groove is. So where the lines cross is basically where I want to ideally place that implant. And we would do the same thing in the anterior. Kick the field goal. And then from the incisal edge of the cuspid to the central groove, draw another line. And that's basically where I would like to place my dental implant. So we're going to take our motor. Now the motors that are provided us are for laboratory hands-on procedures. So they're not quite as sophisticated as the motors that you'll have in your practice, and Glidewell has a wonderful motor that they can provide you. But let's start the process, and what we're simply going to do is we're going to take that 1.5 starting burr, which is very pointy, it's very sharp, and trying to work on the same side as the patient, but for video demonstration I'm going to move things around. I'm looking how should I angle it? Should I angle it like this? Should I move it distal, or should I be straight on? And you can see by using the lines on either side of the tooth, I'm basically kicking the field goal right down the middle. So we're going to run it at about 1,000 RPMs, and I'm simply going to go through the soft tissue into the bone just a few millimeters. Now this burr is very thin and it can break quite easily, so just go into it a little bit, into the bone just a little bit. Now if you wanted to, we could conceivably stop and take a radiograph and make sure that we're ideally positioned. So I just went a little bit into bone. And that soft tissue may come out, just kind of bear with that. So let's assume that our soft tissue is 2 millimeters here, but we can certainly take a periodontal probe and measure so that we can see that we have about 2 millimeters of soft tissue. So if we're going to place an 11.5 millimeter dental implant in bone to the crest of the bone, that means at tissue level we will measure to about 13.5. Well, how do we do that? Well, it's most imperative that we get angulation first. So I'm taking my 2.4 pilot drill, and since I have that initial opening, I'm looking at parallelism, and I'm going to go in and out, and I'd like you to use 2 hands if you can. Gives you a little more control. And I didn't go to complete depth there, but at this juncture what I would do, as we've demonstrated clinically, is we want to ensure that we are right on mesial distal, buccal lingual. Are we in the correct position that we want to be? If not, this is the time to correct it. Now again, using the Hahn system, which is just wonderful, we know that we want to put an 11.5 by 4.3 diameter implant into bone, and we have 2 millimeters of tissue. So I'm going to take the 3.0 burr that is measured at 13, and you can see the black line. You can see the black line there. And it makes it very easy to see to soft tissue depth. I'm going to hold this soft tissue down because it wants to rotate out. But what I'm going to do is I'm going to go to 13.5, so a little bit past that line with the 3.0 burr. That's very easy to see now. And up and down, pump, and just a little bit past 13. So you can see our opening in the soft tissue. Now, we don't want to place soft tissue into our osteotomy site, so this is where I will use my tissue punch. I'm not sure we're going to have a tissue punch in your kit, nor am I sure that we're going to be able to use this rubber. But I'm going to take this circular blade about where my initial osteotomy is, and I'm simply going to remove the soft tissue. And this is what you'll see clinically. So the soft tissue is removed, and we can continue our osteotomy to position. Take my 3.5 diameter by 11.5 osteotomy burr, and you can see it's tapered. And this is just a little bit smaller than the implant itself. The implant's a little bit larger than this. And I'm going to, you can see the little burgundy line on there. The bottom of that line is about 2 millimeters. And so I'm going to bring the heavy burgundy line or magenta line to the soft tissue level. Again, and you can see I have a drill extension on here to give us a little more room and to show the video. This is going to be a very quick burr. You're going to pump with water, external water, and all you're doing is widening the osteotomy site. So it's going to be pretty darn quick. And you can see I'm at soft tissue there. At this juncture, I would then stop and take a radiograph to establish correct position. You don't want the bevel or the top of this burr to be subcrestal rather than at the crest of the ridge. And to finalize, we're going to take our 4.3 diameter osteotomy burr at 11.5, and same thing, I'm going to go to the bottom of that thick yellow line, angle things correctly, pump, and we've created our osteotomy site. Beautiful. Now, in dense mandibular bone, we oftentimes will want to tap And to tap, what we do is we slow down our motor. We set our speeds to 25 RPMs at 25 Newton centimeters. And this is going to create the threads for our implant. And we will go to the line that's recorded there. And again, it's going to go very slow. And it's creating our osteotomy site. And we're there. We will then put the motor in reverse and simply unthread it very slowly. So again, to demonstrate, you can see how slow that's going in. And again, we've created our osteotomy site. And that's going to establish the threads so that the implant goes in passively. We have a couple components. We have the implant driver that you can put onto your handpiece and again set it at 25 Newton centimeters of torque. Or if you want to hand tighten, you'll use the adapter and connect the two and simply take the handle and connect them. And we can insert that into the implant itself. But let's use our handpiece here first, okay? I'm going to put this aside. We set our speed at 25 RPMs at 25 Newton centimeters. Now we're going to place the 4.3 implant. Now this is really good. So what I want you to do is I want you to hold where the implant is. You can see where the implant is in the housing. I want you to squeeze that so it doesn't move, and then simply take your driver, place it so it snaps in, and then on the other side squeeze, and the implant will come out very passively. And if we rotate at 25 Newton centimeters, you can see how slowly that implant is going to go into bone. So we're going to take our implant and go to site. And very slowly it's going to rotate to position. Now I don't want you to put the implant in all the way. That beep at my handpiece stopped it at about tissue level. Now we're going to hand torque this to the correct position. We're above the tissue. Remember, the tissue is about 2 millimeters, so we have about 4 millimeters to go. But we're already at 25 Newton centimeters of torque. So here I'm going to use my hand torque. And again, I'm going to take my adapter and place it into the implant driver. I'm going to take my torque wrench, look where it says Newton centimeters, and I set it to 30 because we know it stopped at 25, right? And let's see what kind of torque we can get now. Now, I strongly recommend that we do quarter turns. Quarter turns. So 4 quarter turns is about a millimeter approximately. So 1, and it clicked, and it simply bring it up to 35, 2, click again, 3, and we're at 50 Newton centimeters there, and it's clicking. But I would stop and take a radiograph and see the position that you're in to make sure that the bevel is at or just slightly above the crest. So let's take the soft tissue out, just see where we are. So, pretty darn good for a first timer. That's nice position, but we would verify that with our radiographs. And when we're completed with that, we again take our handle and then our inserting instrument, then take our cover screw and our inserting tool, simply go to the implant and hand tighten this in position. If we're going to place an abutment, because we got such good torque, then we would place the healing abutment above the tissue slightly. That becomes a one-stage surgery, and you can torque that to 30 Newton centimeters, or about 10 Newton centimeters less than you torque the implant. So what that means is that if you torque the implant to 25, you're going to torque the healing abutment at 15 or 20, and that way it won't rotate out. So let everybody practice that, and then we'll move on and we'll do the second implant. Same technique. I'm going to do it a little bit quicker though, if that's okay with everybody. So let's do our second one. Again, we're going to go a little quicker this time, and you can see there's not a lot of process here. We're going to parallel. So let's get our angulation. Mesial distal buccal lingually. We'll take our 1.5 diameter burr and simply make our initial penetration into bone. We will then take our 2.4 diameter burr, idealize the placement. I would then stop and take a radiograph to make sure you're completely happy with the mesial distal and facial lingual direction. You can idealize every case. I would then take my 3.0, again angling it, and assuming that we have and that rubber wants to come out, but we have 2 millimeters of tissue. I would simply take the 13 millimeter diameter 3.0 drill and just go past the line a little bit. We're then going to take our final osteotomy burr, which will be an 11.5 length by 3.5, our final burr here, and again angle it correctly. I'm trying to hold this soft tissue model. And go to the bottom of that line as we showed before. And just for fun, let's do this one without tapping. And you can take the handle and the extension, the implant driver, connect the pieces, and simply hand tighten the implant and go to soft tissue depth. And we can simply take our torque wrench and again with quarter turns and place the implant to proper position. Here again it's 50 Newton centimeters. Our direct driver and our cover screw, and as we did before, and tighten it into position, hand tighten it into position. Take our radiograph and you are basically done. Let's just take the soft tissue out to see how we did. So you can see we have a little facial defect there where we broke through the model. But that was just me sliding, I think. And that's pretty much ideal position with the bevel just above the tissue crest. That is just ideal. So if we can try that, we'll become pretty proficient in our implant placement. You can see mesial distal buccal lingually. We're in pretty good shape. And this will allow the laboratory to prepare an ideal abutment, an ideal crown. And when you select cases like this, you really can become an exceptional surgeon and just create wonderful emergence profile with your patients.